Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Great to be here. Today, we're going to do something a little different, which seems like it's happening a lot, doing something a little different.
The difference has become the norm.
That's actually a good thing, I think. We're going to be talking about one of the editor's choice collections, Mental Health Disparities by Race and Ethnicity of Adults, that was edited by Dr. Ayana Jordan. And this is the set of articles that I always talk up at the end of each of our podcasts. I refer to this new feature of what I call their editor's choice collections or electronic special issues. Looking forward to it.
So we are very fortunate to have Dr. Ayana Jordan with us today. She's the Associate Program Director of the Adult Psychiatry Training Program and Assistant Professor of Psychiatry at the Yale University School of Medicine. So, Dr. Jordan, thank you so much for joining us here today.
So happy to be here with you all to discuss this really important topic. Thanks for having me.
So this is a little bit different for us. Usually we're talking about a couple articles or interviewing somebody about one particular article, but this time we're going to talk about actually the editor's choice that you edited, I think it was almost a year ago now, in June of 2019, on mental health disparities by race and ethnicity of adults. This is something that's extremely important, and it was extremely important and topical then, and it's all the more so now. But before we dive into the collection, can you just let us know a little bit more about your career interests and how you ended up editing the collection?
Yeah, thank you so much. Any opportunity to share a little bit about me is welcome. So, but I won't go on. I think it's important for people to understand that I really came to do this work. And when I say do this work, really trying to be sure to center Black voices within mental health, kind of serendipitously. I started out in my career really interested in infectious disease, and I always said I would go and be internal medicine and specialize in infectious disease, and I have a PhD in immunology. So the first 10 years of my career really had nothing to do psychiatry per se, although peripherally, as we know, that the immune system has some effects on neuropathology. But really, my deep kind of experience in understanding mental health disparities came when I was finishing up my training program, and I trained in the best city on earth, which is New York City, Albert Einstein College of Medicine of Yeshiva University at the time. And I'll tell you, I had two rotations that I put to the very end. One was psychiatry and one was surgery. I will definitely not be going into either one of those specialties.
Incredible.
But in all seriousness, when I did my psychiatry clerkship, it was in the South Bronx, and I was just overwhelmed with the amount of inequity that was present, specifically within mental health. I had never, ever, ever seen truly anywhere, and definitely not in the United States, poverty at that level. Wow. And the number of predominantly Latinx patients that were hospitalized and really not offered any type of culturally informed or patient-centered treatment options was deeply painful. And I remember being the only person of color in the medical profession and definitely on the psychiatric ward at the time. And all of my attendings and all of the nurses and everybody was white. And it was just like a get out moment. Like Get Out hadn't even come out yet. But what I mean by that is just really feeling like this is unsafe, that we're surrounded by people that may or may not understand our cultural point of view. But definitely, even as a Black person, there was so much that I didn't know about the Latinx culture and how that plays into not only mental health experiences, but symptomatology, right? And so that really piqued my interest in terms of, I think I can do this better. And I really started to question, can I combine my love of research in a way that advances equity in mental health? And so that really transformed my life. And I started to have some kind of, I call them come to Jesus moments, but just open conversations with my mentors about psychiatry, because I was excited. It was tough, but I was excited to get to go to work. And everybody said, Ayana, are you crazy? You
there is some irony in that.
So anyway, the kind of spoiler alert is that I did make the switch, and that's how I ended up at Yale, because it was important to be at a place that would be open to non-traditional way of coming to this work. And that was back in 2011.
Wow.
Well, thank you for sharing that journey. I think it's always so fascinating to hear people's personal journeys of how they came to their work. And I think it gives so much more context to the work that you did for the journal and putting a collection together, your passion for the work, and also how it kind of affects you personally, and has you have a real connection to this. These aren't just papers, these are real things that have consequences for people's lives. So I think that's a great way to frame the discussion. Okay, so that's how you got into psychiatry and ended up at Yale. How about how did you end up editing the collection?
Yeah, so I was really excited, and Lisa doesn't know this, but I've been a big fan of hers actually for a long time. And being involved in the American Psychiatric Association as a leadership fellow allowed me to meet and really talk to people who I thought were really like greats or heroes in the field. And so as a leadership fellow, the opportunity was presented. Lisa Dixon is the new editor and really is interested in understanding the experiences of early career psychiatrists and would love to have you all on. And my name was recommended. And so I said, absolutely, I would love to kind of take advantage of this opportunity. And I think when we're talking about racial and ethnic disparities, I just want to really be sure that we draw attention to giving people opportunities. A lot of times, early career psychiatrists have to wait until they are like mid-career to even be at the level to shape kind of the content or the direction of a scientific journal. And so this is just an example of Lisa really being committed to understanding what are some diverse experiences and how can that also be credible in moving things along. And so I think really being deliberate and using that as an example as we think about mental health disparities is how can we include people from different backgrounds that, because of white supremacy, don't really have a seat at the table, and how can we allow them to really participate in the process. So that's how I kind of got to be a consultant for the journal. But then, in thinking about what is important, and I always say that I would love for white people to do this work. Like, believe me, like I am exhausted at this point because being kind of a Black woman in America and in science, it's never been easy for me. So I always say I don't want to be the one that has to always focus on racial and ethnic disparities in mental health. But unfortunately, people shy away from it because maybe they feel like it's not important, or maybe they feel like they don't have enough expertise to really do it well. I think there's a myriad of reasons, but within our group, I knew that this had to be done. And I was interested in also, like, what are the papers that really speak about this? What is the data? Like, what do we know? And so I really said, okay, I'm an addiction psychiatrist and I am a health equity researcher. But for me, the first one that needed to happen that really is the underpinnings of all of it is really understanding disparities. And I think that's just a euphemism, at least for me, and thinking about racism in our field. How does that play out in so many different ways?
Right.
Yeah.
It might be useful for me to provide a little context as well. First of all, Ayana, I am so deeply moved by what you said that I can barely speak. But anyway, thank you for your confidence, and I hope to continue to earn it. And it does. We have so much work to do, but So the journal, we did create an early career psychiatry kind of working group, which will continue and evolve, and hopefully giving more people a chance to have this voice. And then the early career group decided that one of its activities was going to be creating these collections. What I call them are like sort of electronic special issues that will bring focus to a particular topic of that early career psychiatrist choice. And so we have that on the website, and the importance of the topic you selected, it's right on. I'm glad that you did it. And anyway, I'm curious to hear now what more perspectives from you on this area.
Thank you so much. I think there's a lot, right? There's a lot, and there's many different ways that we can go. But I do want to just highlight a few of the articles that were part of the original collection last year, because I think it's important in terms of just allowing people to have some education in terms of where are we at as a field and providing kind of equitable psychiatric services to everyone. So for those who haven't had a chance to check out the collection,
check it out.
This is your chance before we update it. But I think everyone at this point, and we talked about it extensively in the collection, is the 2001 landmark article from the Surgeon General report of mental health and culture, race and ethnicity. So really that underscored, I think, the importance of the significant disparities, because a lot of young people, and I know this from working with residents, they don't have a deep appreciation for the level and the depth of disparities that really exist, right, based on race and ethnicity, in terms of not only engaging with the mental health system, but also in outcomes, right? So even with racial and ethnic minorities engage with mental health treatment, although it's much less than the majority population in this country is white people, even if they engage, they have less than ideal outcomes. So I think that's important in terms of the collection, to really read the 2001 landmark Surgeon General's report. And
hey,
then,
Ayana, can I interrupt you one more time, because I need to do a shout out to the previous editor of Psychiatric Services, Howard Goldman, who was the senior scientific editor of the Surgeon General's report on mental health. Gotcha. And made sure that there was a special supplement, a special additional material around disparities and ethnicity on the Surgeon General's report.
Yeah, and that's good to know. That's a history that I didn't know. So that's good to know for sure. But what's really nice in the collection is really trying to distill down what are the issues that we're talking about, because the topic is rather obtuse, right? It's so broad. How can we provide a little bit more nuance to it? What we've already done is really have different sections so you can directly kind of engage with the topic of your choosing. So first we dig into what is the problem, characterizing the problem, really understanding mental health disparities by race and ethnicity within psychiatry. So those are things like measuring trends. What are the assessments that we're using? And Benjamin Cook does that really well. Cultural competence. This is the lit review by Mario Hernandez and colleagues that really gets into understanding the core of our issues. Then we go into financial considerations. That's another subtopic within the collection. And this really looks at what is the cost if we're going to improve mental health services for racial and ethnic minorities? Does it really save us money? Spoiler alert, it does. And so if we look at Cook et al., they have a really nice paper of the costs and benefits of reducing racial and ethnic disparities in mental health. And they look at the cost saving for treatment on an outpatient basis. And what they found is that compared with whites, Black and Latinos that actually had 1 year of outpatient mental health care, that resulted in less spending down the line in terms of inpatient services. So here we can see that it's actually cost effective, right, to really invest in outpatient mental health services for all people, but especially Black and Latinx folks. Okay, so that's the financial considerations. Then we go on to quality of care received. And then Andrea Alexis, she really looks at what are the changes in the quality of care from the 1990s to 2003. So then you have that background in terms of, is there reduced quality? And she gets into that. So that's really nice. And then transitioning now to proposed solutions. And that's the last subtopic with the collection. And that's really nice because that's where I want to do a jump off from that in terms of the updated collection.
Right, exactly.
More on those solutions. And I am deeply inspired by one of the papers in that collection in terms of proposed solutions, which is Sidney Hankerson's work. And he talks about church-based health programs for mental health disorders amongst African Americans. And there's an entire review of the literature up to 2012 in terms of where are we at in terms of church-based health promotion and how do we move forward. And I'm really excited to say that, Dr. Hankerson was just funded for this work. So this is an example of someone, despite all odds, really moving through a system that is not necessarily built for him to be successful, but still going through that. So wanting to highlight his work moving forward. And just kind of a really personal note here is that a lot of the work that I do in terms of increasing access to evidence-based treatments for substance use disorder was really inspired, right, by Dr. Hankerson's work. And that's why I do a lot of faith-based health promotion, because there's already inherent trust there. So stay tuned, guys. We are really pushing the needle, and I'm so happy that Psychiatric Services is at the forefront of this work.
I'm glad to have you highlight Sid Hankerson's work. He's actually going to become a member of our editorial board.
Brilliant.
So, yeah.
Here we go. We're doing the work. Yes. And I hope, Lisa, you can say a little bit about the statement and the work group that you've already established with Dr. Stewart and Dr. Isom, because I think people don't understand that that's a first step, right? You have to make sure that these people have a voice at the table, for sure.
Sure. Yeah, Ayana, that in fact, so there is a statement from me on the Psych Services website. You have to click on it. You have to click on the phrase, a statement on racism, but it acknowledges, and I acknowledge, the deficits in, I would just say actually in academic psychiatry and its journals on real attention to systemic racism and the role of racism in determining access to care and access to timely, high-quality services. I mean, and psychiatric services is no exception. And I think, again, with the collection, you see what we've done, but you also see the limitations of what we've done. And it's painful, frankly. It's painful. And so this journal is not the only one. I think there are other journals and efforts that are going to be working on correcting this. But in our case, at least one of the steps that we've taken is to create an advisory group led by Drs. Alpha Stewart and Jessica Isom, who are amazing people. And with them, we've created an advisory, really an interesting, diverse group of people with, coming from different perspectives within the mental health system. I feel very strongly that this is not just psychiatry. We need to, if we're going to fix this, it has to be across, all of our disciplines and perspectives, including peers, I would say, including people with lived experience of mental illness. And with this advisory group, we're going to be making a lot of changes over, moving forward. And this advisory group is not a temporary advisory group in the same sense that the early career group is not temporary. It's something that we will keep and grow and move forward. And, we really need to, and I don't want this to be, I have to cut myself short here because I can start going on, and this is getting, we want to hear from Ayana, but, everything from how we solicit papers, how we review papers, how we promote them. And I'll say one other thing about mentorship, that I really believe that has to be a part of kind of every process along the way as well. And we can do that in many ways within the journal. And I would just say, as Ayana said, this is only the beginning. and that, I welcome, and I know Jessica and Alpha will welcome any suggestions and ideas. And this is a part of our new beginning to address this and get the work that we need to be done and get it out there for people to, from pages to practice.
No, absolutely. Absolutely. And I think where, in terms of really this new collection on race and ethnic disparities in mental health, my vision, and there's been so much important work, again, characterizing the problem, but like I said, really, this is a point where we need to move forward in terms of solutions. And so what I am most excited about, and there might not be a lot of articles, but at least presenting the articles that really focus on solutions. And what I think might be really nice in terms of having in that collection is just a short list of recommendations in terms of what were the highlights from that article that really talked about ways in which you can integrate anti-racist behavior in clinical care. Like, what was the one or two take-home points from that article that really talks about ways in which physicians, researchers, providers can actually integrate anti-racism behavior in their care? Because a lot of people really just don't know. So I think that would be really nice to really think about how can we highlight that in this kind of next collection. Also, in terms of just the background discussion and introducing the collection, I think it would be important to think about, we're past the time of trying to convince people that there is structural racism that happens within medicine and mental health. So really a call for people to go ahead and do the education you need to believe that this exists. But also, let's just start with, it exists, guys. There's no convincing that needs to happen anymore. And so that really feeds our mind up to, if we already come with the default that really what we're doing is racist, and not that it's intentionally racist, but those are the systems that have been set up, right? That systematically disadvantage people who are not white. So if we just understand and accept, one of the things that we can do is it frees our mind to really consider, well, what are the solutions to that? And so I want to present in the summary background in terms of selection is that we just have to come with the default that we're working with an inherently racist system, and then what can we do about that? So I really like the idea of having some points from the articles of what are these anti-racist practices, for sure. Yeah.
I think in some senses the collection that you've already put together is the background, right? This is is part of the background. It's not all of it. But, we have all these well-documented disparities in mental health care and outcomes. And so this is the evidence, and you're pushing the journal to move a step past that. So, in some senses, this is your reading list, right? It's part of your reading list. So this collection. One thing that stood out to me in reviewing the articles is that I didn't see a lot about some of the causes of the causes of the causes. So I didn't see very much about residential segregation, for example, and governmental policies that have created this systemically racist,
environment where we are.
System. Yeah. So I think those are, and it seems tricky to also merge that with your call for solutions-based focused, and I wonder if there's also room for more discussion about how healthcare systems and mental health care systems and practitioners in general can engage with some of the more really policy level, historical and structural issues that have led us to where we are.
Josh, I love you. I just met you, and I am you got to do that on your own time. So I hear you, but I really feel like that might be a place where psychiatric services can have a reading list in terms of the historical policies that have created the inherent systemic racist institutions in which we operate. Like that could be important. That couldn't be the title because that's way too long. But I do think there might be a space to just have access to some of those reading materials, podcasts, so that people understand that. But I think in terms of if we're really thinking about how can we be leaders in 21st century medicine and psychiatry, you have to be able to do that work already. Like that's baseline, right? And so one of the things that I can think about is like the 1619 Project. That's been out now for almost a year. That's an amazing podcast that is broken down by how racism has a historical underpinning in every single aspect of our this culture, right? History, medicine, art, like that is great. JAMA has a wonderful, when did it come out? It was co-authored by a U.S. rep. But anyway, they have a great policy paper that they just came out in terms of looking at how to understand disparities related to COVID. So that could be in kind of the reading list of the homework that needs to be done. But in this updated version, I really do want to focus on solutions because I think we need to move people from doing journal clubs. And I love when Danielle Hairston, who was the president of the Black Caucus of the APA, she said, you know, when Black and brown people get killed, white people have a journal club. And it's like, we have to move past journal clubs. Like, it's great. And you can do that work on your own time. But how can we really focus our efforts and our energy and our time in solutions? And so that's really the call, is that do the work on your own time. We can help you, but you're all smart people because you have made it to this place so that you understand the history. And then what we can do is really be at the forefront of pushing interventions that directly address these historical and current inequities in healthcare. So that's kind of where I'm at. And I know it takes a shift because a lot of folks want to get to the history, and the history is important, but I'm just saying you have to come understanding that, or at least accepting that. And in order to do that, you got to do your work. Yeah.
It's a point very, very well taken. Assuming the knowledge and the background, I think the combination of that with what is the next step for that. So once you come with the knowledge and the background, you understand the as you said, historical and current policies that are creating this environment. Are some of those interventions that we're talking about developing and highlighting, are some of those clinical, or some of those more geared towards institutional interventions? I think that there's an overlap between, once you do understand the situation, what is the next step? And and I guess my point is, some of those steps aren't just going to be clinical interventions or changes in cultural competency within organizations. But there's a broader question of how do you engage in these institutionally racist policies once you do understand them.
Yeah, I'm with you on that 100%. It can't just be, and I'm with you. It cannot just be on an individual level. It really has to be at the structural level, because, you know, we've done implicit bias training, we've done cultural competence training, cultural humility, whatever you want to call it, and that has not moved the needle. In certain cases, we're worse in mental health than we were in the 70s. I mean, that is the reality. And to your point, it's like, what are the structural changes that can happen? And so that's really what I want to focus this next collection on. What are people doing? And it may not be specifically within psychiatry, to Lisa's point, because this has to be just interdisciplinary in medicine. But what are the lessons learned that we might be able to understand from things that have worked out really well?
So I'm curious whether you're aware of some nascent work or evolving work that you think is beginning to identify some solutions. Is the work being done, or are we not even there yet?
So the work is being done, and I'm excited about it because many of the people that are engaged in this work, I know just because their colleagues are going to different meetings. Now, not all of the people that are involved in this are necessarily psychiatrists. So there are people, these are more like social scientists that have a good understanding, to Josh's point, of the historical foundations that really led to this problem. So it pushes us as psychiatrists to really expand our view of who is considered an expert and who's not. And then thinking about, and I would have to do a deeper dive, but for the folks that I know, their work is not necessarily published in psychiatric services. You know, it might be more like an AJPH. There's really nice things, and even looking at our very own Ruth Shem, who's on the editorial board. I mean, she just published in Stat News a list of recommendations, and that was in the popular press, right? And so there are some really nice pieces that we might be able to highlight of researchers or people involved in equity work that have some solutions and are engaging in this work, but might not have necessarily published in psych services and may not come from a traditional academic background. I'll just say that. Again, that's kind of the tension for me, because it's like people are doing this work, but they are not in the traditional journals that we might look to or read as psychiatrists. And can we expand to understand that what they're doing is super important, and it can have some great outcomes for us? You know, Helena Hansen, I mean, she's phenomenal, and really thinking about engaging with structural competency as a way to improve health outcomes. And she's published a lot, you know, not necessarily in psychiatric services, but, you know, I think this is important. It might just be a platform to highlight some of these scholars that are engaging in this work. One of the things, and I'll stop talking, but you see, I get super excited about this, is myself and Carl Hart, we wrote a piece about how to think about promoting equity within NIH reviews. I don't know if you guys heard about this, but in Science Advances last year, which is a subsidiary of Science, there was a paper that came out, and it says Black scientists are not being funded to do work that directly promotes equity in medicine because of research topic choice. And it's like, what are you talking about? Like, research topic choice is not the reason why Black scientists are not being funded. And really, so our response was like, to your credit, Josh, we have to understand that this is beyond research topic choice. And that was the name of our editorial to them. That it's beyond research topic choice. It's the fact that most of our review committees are all white, and they don't understand the imminent danger that can persist in continuing to fund research that doesn't really delve into the issues of racism. And so how do we remedy that? It has to do things like breaking barriers. You have to put scholars on the review committee. They might not have the same number of papers, but then why don't they have the same number of papers? Because they're not being funded at the same rate. So really thinking about how can we break down these inherently racist systems that prevent these people from engaging in the work so that they can really be at a place. But then what's really nice is in an article in Science in 2001, it said, even if you control for publications and this and that, people who are not white are still not getting the same level of grants and NIH funding. So then that brings the point, so what is going on? And that's when we talk about the perniciousness and the painfulness of white supremacy, because it's like you can do everything right. You can still do this. You can go to the same schools, but there's still this thought that if you are not white, somehow your work is not nearly as value or might not have as much merit. And so we really have to think about, do we have to blind people's names? Because we know studies that have shown if you have a Black name versus a white name, even with all the same credentials, you're less likely to be funded. So in the review process, we might have to blind people's names to really minimize, right, our own inherent biases towards folks. Another suggestion that we talk about in this paper is thinking about an equity factor score or supplement score as a way to account for scientists who may come from lower quintile schools, because those are the only schools that would accept them because maybe they didn't have, a certain score on a standardized exam. I mean, these are the things that we have to start thinking about in terms of structural issues that all affect who gets funded to do the work and then what work gets published.
So I wanted to clarify something and see to make sure I understand what you're saying. I think I saw the article that you talked about in which one of the reasons for Black investigators or scientists not getting funded was cited as that their topics were not priority topics for the Institute. And I hear you saying that's not the only reason, but is it a reason? Is it possible to view the systematic racism as the setting of priorities, funding priorities is a part of the systematic racism?
So yes and no, because when you look at the paper, even when you look at overall research topics that were funded at a higher rate, it's true that more mechanistic studies were funded. That is true. But even if you look at more research topics that deal with disparities and, health equity research, under those topics, white researchers were funded at a higher rate than Black researchers. So then that begs the question, it's beyond research topic choice, right? Because
so I think it's not only. I think the question I was asking was, is it a part of it? It's not that is it everything or even the majority, but is it? I mean, it just seemed to me that there's some face validity to the idea that we need to sort of promote scientific advocacy, in the words of Pamela Collins, with whom I spoke, that to try to focus our funding agencies to fund research on topics that are relevant to people of color. I mean, to all of us. But, so I guess I just wanted to clarify that, make sure I understood.
Yeah, and that's a good point. So, yes, there is definitely a contribution for sure. And that is, to your point, is something that can change in terms of why aren't these research topics more important? Why aren't they the priorities, especially what's happening in our society today? And yet we still have to reckon with, even if they were a priority, which they weren't, that still would not be enough to get us over the line, because there's still inherent racial discrimination when you're looking at who's funded based on those topics that promote health equity. And that's kind of what people don't really wrestle with enough,
Yeah. So clearly the solutions need to be multi-element.
Yes.
And not, as I hear you, avoid the fundamental sort of clear, direct, almost individually directed or racism that occurs and is a part of, that impacts everything from top to bottom.
Exactly. Exactly, Lisa. You have summarized it eloquently, and really thinking if we miss this opportunity, now is the time, right? We are at a point in American history, our children and great grandchildren are going to look back and say, what did you all do here? How did you fundamentally advance science and medicine at this time? And if we miss the opportunity to really address the fundamental possible mechanisms that underlie this virulent problem, which really is racism at its core, then we'll continue to subjugate people to unfair treatment and its consequences, right? And so that's all that I'm asking for when I say we got to focus on solutions. And all of those solutions, they may look differently, but they have to be rooted in anti-racism.
Well, that seems like a great summary of both the collection and also the next steps. And, I just want to thank you so much for joining us on the podcast, and also all of the work that you're doing. So, and then coming on and taking time out of your weekend to join us here. I'm just incredibly appreciative of all of the all the work that you're doing.
And
so thanks for having
concur.
me. Thanks for coming on.
Yeah.
Thank you for. This was great, guys.
I want to echo what Josh says, Ayana, and also thank you for really challenging us. As enthusiastic as you are, which you are, you are pushing. You're saying this. We need to do the work now.
Yeah.
And I think that conviction and seriousness and intensity comes through. And thank you for doing the collection, and thank you for pushing us to do better.
Yeah, awesome. Thanks for listening. Thanks for listening, for sure.
Well, that's it for today. We invite you to visit our website, ps.psychiatryonline.org, to read the articles that are in the Editor's Choice collection that we discussed, as well as other great research. We also welcome your feedback. Always, please email us at psjournal@psych.org. You can also rate and review the podcast on iTunes, Stitcher, or wherever you listen to it. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk to you next time.